Welcome to Complicating the Narrative, a podcast that takes on the challenging questions in public health by embracing complexity rather than avoiding it. I'm your host, Salma Abdullah. Few issues capture the interconnectedness of global health quite like antimicrobial resistance, or AMR. It's been called a silent pandemic, threatening to make once curable infections deadly again. But AMR is more than a biomedical crisis. It sits at the intersection of agriculture, livestock treatment, medicine, economics, and global inequity. My guest today, Professor Sabiha Essack, has been one of the leading global voices in framing AMR through a One Health lens, connecting human, animal and plant, and environmental health systems. She's the South African Research Chair in Antibiotic Resistance and One Health, and Professor in Pharmaceutical Sciences at the University of KwaZulu-Natal in South Africa. She's also on the scientific board of a number of international entities dedicated to AMR. She's also been a powerful advocate for centering equity in global AMR responses, particularly ensuring that low and middle income countries aren't left behind in tackling the growing burden of AMR. Sabiha, welcome to the podcast.
Thank you very much.
So what I wanted to start with is just really first an introduction to what AMR is, or antimicrobial resistance. I know a lot of people probably just read the articles that says superbugs or listen to a lot of conversations about how we might go back to pre-antibiotic era. But it would be helpful to get an explanation of what is antimicrobial resistance and what is its growing impact on health and on the planet as well.
So, antimicrobial resistance, or AMR, is often described in dramatic form: the rise of superbugs, the next pandemic, a post-antibiotic apocalypse. But here's the thing. AMR is not just about microorganisms outsmarting antimicrobial drugs. AMR is a reflection of how our global health, agri-food, and economic systems work. It's about systems, power, governance, innovation, communication, and equity. It's about whose lives are saved, whose voices shape the solution, and whose economies absorb the costs. In a word, it's complicated.
So then can you tell us a bit more about what is One Health? You're one of the biggest advocates, as I mentioned, to this approach. What does that mean?
So, One Health, let's go back to basics. So, One Health is a collaborative approach that recognizes the interconnectedness of humans, animals, plants, and the environment. It's based on the idea that challenges and solutions don't exist in silos. For example, antibiotics are used in livestock, can affect water systems, which in turn impact on human health. When it comes to AMR, the One Health approach is essential because resistant microorganisms spread across species and across borders. But here's the catch. While One Health is a powerful framework, its implementation reveals stark inequalities. Power imbalances are evident in several ways between the global north and the global south. And I'm going to give you 3 illustrative examples of power imbalances related to resources and capacity, agenda setting, and the environmental dimensions of AMR.
So what are those imbalances?
Sure.
And how do we see the burden differences between countries? Yeah.
So let me start with resources and capacity. High-income countries like the US, the UK, Germany, Australia, in the global north have the labs, they have the funding, they have the surveillance systems to monitor and mitigate AMR across all of the sectors that I mentioned. They can afford genomic sequencing, advanced diagnostics, and real-time data sharing. The LMICs, on the other hand, low and middle income countries, often don't have these resources. Their surveillance systems may be fragmented and definitely underfunded. This means that the global data on AMR is skewed, dominated by high-income countries, while LMICs are underrepresented. And that really affects decision-making. Global strategies are shaped by the data we have, not necessarily the data we need. So that's speaking about resources and capacity. I also mentioned agenda setting. So the higher income countries actually dominate in agenda setting. These actors may prioritize AMR strategies that align with their own interests, such as pharmaceutical regulation or hospital-based interventions, while underemphasizing the agricultural or environmental dimensions that are more relevant to LMICs. And here's where ethics comes in. Some policies, like restricting antibiotic use in livestock, may be necessary, but they can disproportionately affect LMICs. Imagine being a small scale farmer in Kenya or Bangladesh, told to stop using antibiotics without being given the biosecurity alternatives. That's not just a technical issue, it's a justice issue. And then my final point in terms of the power imbalances relates to the environment. The environmental dimensions of AMR, like antibiotic residues in rivers or soil, are often underregulated. And LMICs may suffer more from environmental contamination due to weaker enforcement and industrial practices. Yet LMICs lack the voice to push for stronger international standards. It's a classic case of environmental injustice. Those most affected have the least power to change the system. So AMR is a global issue, but the fight against it is shaped by unequal power. The One Health approach helps us see the full picture, but it also reveals who is missing from the conversation.
So I've been looking at some of your papers. I really appreciated the one on One Health stewardship. I think it was in communications medicine, One Health stewardship in tackling AMR, and we'll put a link to it in the show notes. Because at least for me, as someone who came from clinical medicine, but also does work in public health, it still gave a good perspective of taking a planetary and One Health approach to AMR. So I really appreciated that. But it was really interesting to me reading, even though I knew it, but I didn't really know the numbers. Is I think about their expected annual death from bacterial resistance, about 7. From fungal, it was 3.8 or 3.7 million annually. And then I read the sentence after it, which says that most of those deaths are going to happen in Africa and South Asia. And I think that's the part to me that was challenging, because then, as you said, most of the practices are happening in high-income countries, but AMR is disproportionately affecting low- and middle-income countries. And how do we square that? Why are countries in low- and middle-income countries are mostly affected despite this practice being driven by wealthier nations?
So 3 points with regards to why there's a disproportionate burden in LMICs. First of all, weak health and regulatory systems. Secondly, limited access to diagnostics and alternatives. And thirdly, LMICs have the greatest proportion of vulnerable populations. So let's start with the first one, the weak health and regulatory systems. Most LMICs, or many LMICs, are plagued with weak health and regulatory systems. There may be no robust systems to monitor antimicrobial use, enforce prescription-only policies, or track resistance across all One Health sectors. The human health sector is most advanced when it comes to AMR surveillance, followed by animal health sector, while there's the environment sector and plants are really in their infancy. So this makes it really easy for resistant threats to spread undetected and untreated. And without strong surveillance and regulation, AMR becomes a silent epidemic in LMICs in particular. The second point, LMICs may have limited access to diagnostics and alternatives. Imagine being a doctor in a rural clinic without access to a laboratory or laboratory tests. You prescribe antibiotics based on symptoms alone because that's all you can do. Or imagine being a patient who can't afford a doctor's visit but can buy antibiotics over the counter. It's cheaper, it's faster, and it feels like a solution. In LMICs, these scenarios are very common. And alternatives like vaccines, improved sanitation, or biosecurity in farming are often unavailable or unaffordable. The result? A cycle of dependency on antibiotics or antimicrobials in general that fuels resistance. And then my bit about the vulnerable populations. LMICs have higher burdens of infectious disease, malnutrition, poor water sanitation and hygiene, all of which increase the demands for antibiotics. And when resistance emerges, the consequences are more severe. Access to second-line treatments, intensive care, and advanced diagnostics is limited, and the most vulnerable populations unfortunately hit the hardest.
Yeah, I think I think this is also the challenge here, as you said, especially if you're working in LMIC as a physician, and I did work in Sudan. Is that if you're the individual doctor, you're sitting in a rural area, or even in Sudan, sitting in Khartoum, it's really hard for me to think about the collective need to thinking about AMR. How do we rationalize? What type of antibiotics should we give versus not? Versus the individual that I just have right in front of me. That's always an issue at the individual level, especially if I don't have what it's needed to figure out, like, is the type of microbe that we have here, are we seeing a strong antibiotic resistance? Do we need to provide a different type of medication to this patient? And I think I remember I had a conversation with a colleague who was working with WHO in the Middle East and North Africa. And I think he was saying, I think one of the countries, I'm not sure if this is public information yet, had only one lab that would allow a physician like me to send them some samples to try to figure out what is the right medication to give to a patient here. So I can see that at the individual level. But I think also what you're looking into when you're thinking about a One Health approach are the structural drivers. So generally overuse from people who might be like me, work in a clinic, misuse, or access inequities. So how do we navigate that tension between the individual, the patient's need for the that I have to deal with as a physician, but also collective action that is needed to tackle AMR?
Salma, may I just speak to each of the
Yeah,
components that you mentioned in terms of overuse, misuse, and access inequities, and then I will tackle how we look at the
yeah,
individual patients and the societal
yeah,
implications. AMR, as you know, just doesn't happen. It's driven
yeah,
by systems, behaviors, and inequalities. So if we look at overuse, antibiotics are often prescribed unnecessarily. In human medicine, they sometimes given for viral infections or used just in case without diagnostic confirmation, especially in vulnerable populations. So, for example, in South Africa, we have a very high HIV and AIDS, people living with HIV and AIDS. And doctors prescribe to err on the side of caution. And you can understand that because this is a person with a compromised immune system that is that much more prone to secondary infection. So, yes, we overuse antibiotics. Sometimes it's justified, more often than not, it's not. So,
yeah,
that's the human part of it. In animals, especially in intensive farming, antibiotics are used to promote growth and prevent disease. And in agriculture and aquaculture, they're often used to prevent outbreaks in overcrowded or unsanitary conditions. This widespread use, whether in humans, whether in food animals, creates the perfect environment for resistant microbes to evolve and spread. And then we have misuse, and there's a nuanced difference. In many countries, in many LMICs, antibiotics are available over the counter.
yeah,
People self medicate, often without proper guidance, and then patients may stop taking antibiotics once they feel better, allowing resistant bacteria to survive. And these antibiotics are either flushed down into the municipal wastewater systems or they're saved to be used by others if they happen to get sick in a similar way. And then,
yeah.
without access to diagnostics, healthcare providers often prescribe empirically, choosing a drug based on symptoms and not lab results. So, this is all construing misuse. But most concerning to me are the access inequities. Here's the paradox. In some places, antibiotics are overused. In others, they are desperately needed but unavailable. LMICs may lack access to newer or second line antibiotics due to cost or supply issues. In fact, many manufacturers don't register all of their antimicrobials in all of the countries. So,
Wow.
diagnostics are often out of reach, so treatment is based on guesswork and weak health systems, poor infection control, limited sanitation, and low vaccination coverage means antibiotics are used as a substitute for broader public health infrastructure. And then the final point, Salma, is one of the most complex challenges in AMR policy is the tension between the individual patient and collective public health. So consider this. You as a doctor want to treat a patient effectively. This often means prescribing antibiotics, even if the diagnosis is uncertain. But every unnecessary prescription contributes to resistance, which harms society in the long term. So, how do we navigate this? Global efforts must ensure that LMICs have access to quality antibiotics diagnostics, and stewardship. And we must avoid punitive policies that restrict access without offering viable alternatives.
Yeah, and so this actually brings me very nicely because I've been thinking about this, and as I said, reading from your work, I didn't realize there are a lot of market failures when it comes to antibiotic treatment. I think or development. I usually think of antibiotics and AMR as a problem that happens on us as physicians, and what type of regulations are there for people to consume them. But I didn't also realize until reading more about this that there are well documented problems that there is a market failure here. It seems like pharmaceutical companies are not really developing antibiotics or new antibiotics as needed because there doesn't seem to be a profitable business model, at least from the literature I read. So because it seems like new antibiotics, they should be used sparingly to preserve effectiveness, because that's part of the argument for AMR, which means low volume sales. And if that's the case, then of course, a pharmaceutical company that is driven by profit would not really invest in a lot of the new antibiotics that are needed. So, can you explain this market failure? Did I get it right? Please correct me if I get it wrong. And why do you think traditional innovation incentives are not really working for antibiotics?
So you got it absolutely correctly. The antibiotic pipeline has dried up because the economic model just doesn't work. So antibiotics are actually victims of their own success. They're short-course drugs meant to cure rather than chronically manage. Worse, the effectiveness erodes the more they're used because of AMR, and this makes up the ultimate market failure. The more society needs to protect them, the less profitable they are for the manufacturers. So this leads to a paradox. Society wants new drugs, but doesn't want them widely used. So imagine being an investor. That business model, the traditional business model, just doesn't work. So governments have started to step up or step in with push incentives, grants for early research and development or R&D, and then pull incentives like subscription payments or market entry rewards, or what we commonly understand as a Netflix model. So you prepay whether you watch or whether you use the antibiotics at all.
And I think this is where, for me, it gets a bit ethically complex. I was thinking about this last night. So if we take what we're saying about that there are inequities, and a lot of LMICs are the countries that are really struggling with access to antibiotics. But if part of the model, if we develop new powerful antibiotics, we might need to withhold some of it to restrict access to preserve effectiveness for those who really need it, compared to those who might need it, which seems, at least to me, to create a moral dilemma. I can't imagine being in your shoes and trying to think about new regulations for antibiotics in different countries. So, how do you then think about the ethics of withholding new drugs to preserve effectiveness?
So that is really ethically tricky. If
Yeah.
public money pays for innovation, should new drugs then be withheld from use to preserve them, or should they actually be accessible to everyone in need? And this is, from here, a real dilemma. So what the solution, or like to suggest a solution in this regard, is that the answer lies in stewardship frameworks that are fair.
Mm.
For example, tying access to clear clinical criteria, transparent decision making, and appeal processes. Stewardship doesn't necessarily mean denial, it means appropriate use, justified, equitable use. But we also need to think beyond antibiotics. For example, if we could decrease the reliance on antibiotics, this would remove the selection pressure for the development or the escalation of resistance. And we can reduce our reliance if we think about vaccines that can reduce infections and therefore antibiotic demand. If you think of the pneumococcal vaccine, the influenza vaccine, the RSV vaccine, or even the livestock vaccine, all of them prevent infection and therefore the reliance on antimicrobials. Rapid diagnostics can also guide clinicians towards not narrow spectrum treatment. And then there are microbiome approaches and infection prevention technologies that can reshape exposure itself. And so the paradox is real. We must incentivize innovation without undermining stewardship. And we must broaden what we mean by innovation. It's not just R&D in terms of development of new antibiotics, but there's also innovation in diagnostics, in preventives such as vaccines, as well as behavioral innovations or economic innovations that can help preserve the efficacy of antimicrobials.
So when you say stewardship, then the first word that comes to my mind is coordination and governance, because to actually get to all the alternatives that you're suggesting, we do need really strong governance, especially on a global scale. And I've been reading about this. It seems like there are a lot of entities from WHO, FAO, up to other entities who have put out, including the UN as well, putting out statements that clearly highlight AMR as a global priority. And countries have also developed national action plans, some of them really good national action plans, but it seems like still global coordination that is meaningful is still elusive. What can we do about that?
So you sort of hit the nail on the head that you've seen so many different governance structures proposed by the UN organizations, governance structures proposed at national level by countries, but the governance still is a challenge, and that is because AMR is polycentric. It straddles so many different ministries and so many different sectors, such as agriculture, such as human health, such as the environment, such as trade, and such as industry. So no single ministry owns it. And national treaties or national guidelines only cover pieces of the puzzle. AMR is complex, and AMR mitigation strategies may require compromising sector or ministry mandates for the common good. And compromise is always difficult.
So we're thinking about governance, which is really interesting. As someone who works in social determinants of health, I definitely sympathize with the idea of like if something is polycentric, it is really hard to then to try to find like one entity that leads it through. But I think a second part you talked about that is really important are the financing mechanisms, right? And with financing, of course, whenever there is talk of financing, and if there are also polycentric areas that people need to work around, there's also talk of accountability, then who's responsible at the end. And that's also where it gets tricky to me. And it's been fascinating being exposed to different fields because a few weeks ago, I interviewed someone who works in law. I come from clinical medicine and epidemiology, so we have a certain way of thinking about evidence. Law has a certain way of thinking about evidence and what to implement. And I think that would probably also be something that the field of One Health when it comes to AMR needs to grapple with. So what do you think we should do thinking about financing and of course then accountability for financing, and what type of evidence should we use there?
So you quite rightly say financing is a huge roadblock. Too often countries, and again, specifically LMICs, depend on donor funding. These are usually short 3-year cycles, heavy on workshops, light on sustainable infrastructure and capacity strengthening. And when funding stops, surveillance labs close and trained staff shift away. Accountability is another component that is weak. Many monitoring frameworks track inputs. How many countries have a national action plan? But very few measure outcomes like infection mortality or resistance rates. But that is changing slowly now, Salma, as you can see from the burden of AMR papers that were published in The Lancet. Then there's epistemic pluralism, the way different groups interpret the evidence, as you mentioned earlier. Clinicians prioritize randomized clinical trials. Environmentalists lean on the precautionary principle. Economists look for cost effectiveness ratios, return on investment, etc. Communities bring experiential knowledge. When everyone uses a different measurement or a different yardstick, it's no wonder that we have a policy gridlock. And geopolitics also matters. Trade rules influence how veterinary antibiotics are regulated. Intellectual property regimes shape access to new drugs. Negotiations often put powerful industrial blocs against countries with fragile systems. So, to move forward, governance needs to reward verified functions like labs publishing antibiograms or hospitals meeting their stewardship standards, not just plans on paper.
Yeah. And I think this also then aligns or makes me think about part of the reason why I actually started this podcast is it's not only that we have evidence pluralism and different stakeholders think about different types of evidence, but we also have an issue of what are we communicating? What type of evidence is being communicated? What type of evidence is being privileged versus not? And how does that shape then our actions? So looking at AMR communication, if I just Google thinking about antimicrobial resistance, you'll see that I'll see or at least if you can do it now on your phone, if you're listening on your phone, you'll see that it really heavily lies on catastrophic scenarios. Or apoplectic scenarios. We hear returning to antibiotic area. Certainly, that is not something I want to see. Or there are routine surgeries becoming deadly. That is also another headline that you'll see. Or the end of modern medicine. That is another title that I actually saw looking at information about AMR. So this might grab attention, right? Like saying something like this would get your article opened by people. But does it really motivate action? What do you think? And also, should we move beyond being apoplectic when we're talking about AMR or thinking about superbugs messaging to think about connecting AMR to everyday life? So,
You forgot the one that says superbugs could kill 10 million people by 2050.
yes.
So for years, we've relied on fear. But fear has diminishing returns. It can desensitize the public, and worse, it can stigmatize patients and prescribers. So we need to reframe this communication by connecting AMR to everyday health realities, bring it home to every single person. Remember, AMR is a responsibility, it's a whole of society responsibility. So we need to bring the reality and the danger of AMR home. So something like safe childbirth, reliable cancer chemotherapy, routine surgery, all depend on effective antibiotics. So does thriving agriculture and clean rivers. So AMR is not a distant apocalypse. It's a present day patient and community safety issue.
Hmm. And then then I think this brings up another issue, because you did mention a lot of things that we need antibiotics for, and then people see the apoplectic or really really scary headlines, and then that we also live in a world where we're seeing increasingly just reduction of levels of trust in different institutions, but also in public health and physicians. I've been increasingly interested in the issue of trust, especially post COVID. Clearly, there is some issue there with people trusting public health officials on what is the right way to improve the health of populations. So I've been thinking more about like what we're really asking, especially people on what people would experience on the ground, is the issue of overuse. We're going to ask a farmer to use fewer antibiotics or change their practices. We're going to ask physicians to work on overuse issues that they're going to communicate to their patients. How do we maintain public trust, or especially public trust that is being decreasing over the past few years, while also addressing the issue of overuse or larger issues with AMR?
In a nutshell, policy coherence, where every sector is held to account, and this will build trust. Trust is fragile. Imagine telling patients to avoid unnecessary antibiotics while allowing widespread agricultural misuse or unchecked pharmaceutical pollution. This inconsistency undermines the credibility and the trust. So, communication works best when it's co created. Instead of top down campaigns, involve communities, doctors, pharmacists, nurses as trusted messengers, and use local languages. Share facility level data with patients as well as with staff. And in short, I would say less hype, more honesty, less apocalypse, and more everyday relevance.
Yeah, I think that's a really good way to put it. I think also there is similar conversation now about how do we communicate about climate change. That a lot of what you said also resonates with me on what needs to be changed. So then, hopefully, because AMR as a topic is a really heavy topic, as we think about the future, if we're having this conversation in 2035 or 2045, and we've hopefully made meaningful progress on AMR, what would have changed? What would success really look like? And what would we need to complicate today to actually make sure that in 20 years we'll see that meaningful progress and people would be trusting authorities again?
So, in 10 to 20 years, if all of our mitigation strategies work, then we would have a world where deaths from resistant sepsis decline year on year. Broad spectrum watch and reserve antibiotics are used less because rapid diagnostics and vaccines reduce the need. Pharmaceutical plants meet strict wastewater standards. Farmers are rewarded for producing protein with minimal antibiotic intensity. Every district hospital, even the ones in rural areas, can do same-day bacteriology. LMIC researchers don't just provide data for global models, but set the research agenda themselves. There's inclusive policy making that reflects diverse global realities, technology sharing and capacity strengthening, and a commitment to equity, solidarity, and justice, not just efficiency. But to get to this, some may think utopian uh, goal, we must complicate the narrative. It's not just about patients overusing antibiotics, it's about how markets, systems, and regulations are designed. It's not just about discovering new drugs, it's about equitable access, stewardship, and environmental controls. And stewardship is not restriction, it's better care.
Yeah. It really does sound, at least to me, as a heavy lift. I appreciate that you have that strong vision. But I think just thinking about what we discussed today, so thinking about equity in an interconnected world, thinking about innovation, as we discussed, and also thinking about stewardship, all of this is needed to achieve that vision that you spoke about. So how do we get there? Like, what is that vision that actually connects all of those areas together to make sure that we get to the place that you just described in 20 years?
Yeah. So, besides polycentric governance, I also believe in the power of social compacts. And for AMR, we need a One Health social compact, one where innovation is delinked from sales volume, where stewardship is built into health, agri-food, and environmental systems, and where equity is non-negotiable. A compact where businesses, clinicians, farmers, and communities all have incentives to reduce resistance. And yes, it also means investing in what seems rather boring: water, sanitation, and hygiene, ventilation, and infection control. Those are the highest return on investment interventions we have. Quietly, they save more lives than the blockbuster drugs.
Thank you, Professor Essack. So the last question I usually have for people here is, what keeps you up at night? But I think there's a lot to keep people up at night when it comes to AMR. So maybe I want to leave on a positive note. What makes you think about a future that, if we complicated the narrative on AMR as we just discussed today, what gives you hope that we can actually tackle what is needed to make sure that AMR does not continue to be an issue that faces the human population in 30, 40, 100 years?
AMR is complicated and interconnected. If we cling to simple stories, we risk shallow solutions. But if we embrace the complexity, we open the door to smarter, fairer, and more sustainable answers. So the next time you hear about superbugs, I hope you'll pause and think, whose systems, whose power, whose voices are shaping that story? And what does complicating the narrative reveal about the kind of health future we want?
Sabiha, thank you for joining us today. This podcast was edited by Zach Leonaris and Catalina Melendez Contreras. It is supported by the School of Public Health and Frick Initiative at Washington University in St. Louis. You can access this and other episodes wherever you get your podcast, or you can watch it on video on YouTube. Thank you for watching.